I think the next one on the list, the comparison between UCAL and Lahore protocol and of an induction response in pre-B acute lymphoblastic lymphoma. Is that speaker here? No. So the next speaker is characteristics and outcome of MLL gene rearrangement positive pediatric acute lymphoblastic leukemia, a report on 37 cases from Saudi Arabia.
Thank you for the organizing committee for giving the chance to present our data from Saudi Arabia. So we reviewed these cases. There's a question all the time about what to do with patients with MLL rearrangement, especially after the age of 1 year. We have many studies does for the infantile leukemia with MLL rearrangement, and the last one which showed MLL was not a solo affect the survival in patient and infant leukemia, except for patients less than 3 months. Here, we would like to see how about MLL rearrangement in patients who are more than 1 year of age. So little known about this MLL rearrangement and the significance of this rearrangement. So whether MLL rearrangement is a prognostic importance in children over 1 year of age or not, it's unknown. And what to do with those patients who are MLL rearrangement? Do we need to upgrade the chemotherapy or treat them as high-risk protocol according to this one or not? So here we reviewed 371 non-infantile ALL patient leukemia who was treating in a single institution, King Faisal Specialist Hospital Research Center, over 10 years from 2005 to 2014. We were able to retrieve 13 patients who were positive to MLL rearrangement. So as you see here from this slide, there was low different distribution according to the gender between the MLL rearrangement positive versus negative, both of them almost the age-like distribution evenly. And when we looked for the MLL rearrangement positive versus MLL rearrangement negative for the age, as you see here, 86% of the patients who are MLL negative were in the standard risk group, the age less than 10 years, versus 76% in the MLL positive group, so almost the same. So age was not a barrier. As you see here, the median age for MLL rearrangement negative was younger than the median age for the MLL rearrangement positive, but did not reach statistical significance. Here we look for the leukocytosis, which mean white blood cell more than 100K. As you see here, almost both of them the same, although there is in the MLL rearrangement 2 patients out of 13, which is about 15% versus 12% in the MLL rearrangement negative. For the median white blood cell, again, here is lower with the MLL rearrangement negative. Median was 11.4 versus 35.33 in the MLL rearrangement positive, but again, did not reach statistically significant. So we looked for the M1 bone marrow day 14. As you see here, both of them, more than 90% reach M1 in day 14. We have just one patient, M3 in the MLL group, versus we have 15 patients, which is 4% versus 7%, but it was not significant. For the CNS status, it was not difference between the two groups. It's not like the Philadelphia chromosome. Esteem MLL rearrangement is not as significant to present as CNS 3 as in the Philadelphia chromosome positive. So it was not a different CNS status presentation between the two groups. ALL subtypes, I see here, we saw in the MLL rearrangement negative group, we have 26.1% biphenotypic leukemia. On the other hand, MLL rearrangement, there was no any patient with biphenotypic leukemia. for the T cell, it was a little bit higher in the ML arrangement positive. We were like 23% versus 10% in the ML arrangement negative group, but was not statistically significant. For the relapse rate, it seemed like we have 7.7, almost 8% in the ML arrangement positive versus 12% in the negative group, and it was not statistically significant. For the duration of the CR 1 month by relapse site, we have the median CR1 61.1 months in the ML arrangement negative versus 55 months in the ML arrangement positive. So almost the relapse time is the same, is not early or late. Overall survival, as you see here from the two groups, almost the same between ML gene rearrangement positive versus negative. And for the event-free survival, both groups, they have the same event-free survival, is not different between the two groups. When we comparing MLG rearrangement positive, negative, controlling for risk factor, as we control the age, we found the younger group, it has worse prognosis than the older age, like this patient who has less than 10 years, worse than patient who has more than 10 years. For the gender, male, also the same, and for the CNS status did not make any difference. Day 14 bone marrow, of course, if we have M1, it was a significant, but was not significant for the other group, M2 and M3. And B cell, it was a significant factor versus the T cell, it was not significant between the two groups. So in multivariate analysis, we of the risk factors failed to identify any independent single or interaction of risk factors significantly contributing to the overall or event-free survival for patients with positive AML gene rearrangement. So in our univariate analysis, controlling for various subgroups, we observed that MLG rearrangement positively was significantly associated with poor overall survival in male patient having age at diagnosis less than 10 years, white blood cell count at diagnosis less than 100, and day 14 bone marrow cellularity as M1. However, we could not find any single factor associated with poor survival MLG rearrangement when multivariate analysis. This was perhaps due to the sample size limitation. It was like 13 patients of ML rearrangement positive. So large cooperative studies in the region are needed to explore and establish the role of MLG rearrangement in the outcome of patients with ALL in our part of the world. And thank you very much.
Question?
Thank you very much. This presentation is open for discussion.
Thank you for your presentation. You showed the excellent outcome in MLL positive patients, although it is known that in many Western countries, the results are not so promising. Do you have any explanation why do you have such nice data, such nice result in MLL positive patients?
So do you mean why there is like no difference between the two groups?
You showed survival around 80%. I think it's quite good.
Yeah, I think it's, if you look for the improvement of survival for leukemias for the last maybe 10 years, chemotherapy is not much changes for the last 10, 15 years. But we have a good supportive care in our hospital for supporting nutritional part, controlling for infection, and infusion. We are the compliant rate for the chemotherapy, almost 100%. So I think all of these things, the supportive care rather than the chemotherapy, that improve the survival.
Thank you.
And my question is, how many translocation for 11 do you have in this group with MML rearrangements?
The one we did, like the 13 of them, all of them, they have the rearrangement. So we got just the rearrangement ones. So the one I presented here, all of them, the rearrangement. Patient who has just a translocation with the rearrangement not included with those patients. Only just the rearrangement patient. All of them they have.